The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. Today's guests really excite me because this is something, as a survivor who's more than 5 years out, this is something that I'm keenly interested in myself. I'm joined by Dr. Chris Ray, who's the Director of Cardio-Oncology at Mayo Clinic, Florida, specializing in the complexities of cardiovascular disease in cancer patients, and Dr. Bryan Taylor, who is exercise physiology, I think I said that right, and sports cardiology, who will be answering kind of the questions that came in about exercise. So thank you guys so much for being here.
Yeah, of course. Thanks for having us.
Yeah, thanks for having us.
So let's start super basic. The heart, obviously everybody knows that they have a heart, right? But what are the functions of the heart for the body?
Yeah, I think the simple answer is the heart is a water pump, right? I mean, blood is water. So think of it like a water pump for a cooling system in a truck or a car, or a system to move water through a pump system in a pool infrastructure, right? That's the only real mechanism that it's there for, is to manipulate and move water, blood being that form, right? And blood becomes this transport mechanism for all sorts of things, information and infrastructure, as well as nutrition and support, right? So the heart's just pumping information, support, and nutrition through the body. That's what it's doing.
Wow. Okay. And then I think I read that, or heard in an episode of a podcast or something that I heard that Dr. Ray did earlier a few years ago, that cardio-oncology is a relatively new specialty. Is that true?
Yeah, I mean, there's some people who will say, I've been doing this for 30, 40 some odd years. We know since the 50s, when certain types of cancer therapies, the class we would communicate in that realm would be the anthracyclines, which were predominantly lymphoma, leukemia, and sarcoma drugs. They would create an environment that would weaken the heart, actually physically damage heart cells, heart muscles would get weak. So we've known since the 50s that cancer therapies cause this. But I would say over the last 15 years, there's been a real big push to create a true specialty and really try to create infrastructure where patients who are either about to go through, currently going through, or have gone through some cancer therapy, get an infrastructure and education on cardiovascular care. Chemotherapy, is anybody on this podcast listening knows, is a whole body experience, right? So it's doing its job well, but it also impacts a lot of things. One of those things happens to be cardiovascular disease. So it can impact the pump functions, it can impact the blood vessels, and we'll get into some of the physiology that can occur that can lead to some exercise changes and those kinds of things. And so because of that, I think there's value. The other thing that cardio-oncology offers is another facet and an avenue for enhanced care, right? A lot of patients who go through this process, it's not uncommon for their oncologist to be maybe one of the first points of contact in healthcare, right? So men with testicular cancer, they find something unusual in an exam, their first point, and like, this is the first time I've been to a doctor, right? Because I'm 30 or 40 years old. And so thinking about cardiovascular disease isn't even in the wheelhouse, right? And now they've got this big monumentous event that they have to go through. Cardiovascular disease still isn't on their purview. And so building a clinic where we try to simultaneously enhance that experience for patients, we evaluate and kind of establish a baseline for them is very important. There are a lot of cancers where there's a high survivor rate, and yet the number one cause of death long-term, 15 years or 20 years down the road, cardiovascular disease, right? So why not take the opportunity when you're in the health system, even though you're going through something monumentous, to in parallel evaluate something that's predominantly the main killer in the United States?
Yeah. So one of the questions that we got from Reddit or Facebook was kind of about baseline, and, it's kind of similar to sperm banking, whether it's done before orchiectomy or after. Should there be, cardio labs drawn before chemo? I don't think that I had that in my case. I don't know about other people, but I mean, is that something that should kind of start changing?
It's very reasonable. I mean, we would advocate, depending on your age and risk factors, we would advocate for cardiovascular screening somewhere between 30 and 40 years of age, right? So we're in that kind of wheelhouse where that becomes a commonplace for good baseline screenings, because the predominant mechanism for improving outcomes in cardiovascular disease is early identification and prevention, right? So we want to find the patients who have an aggressively high cholesterol, or find a patient who has another uncontrolled risk factor like high blood pressure, diabetes, talk about smoking cessation, family syndromes and histories. It really makes a big difference. It's a lot like investing in a retirement program, right? If you had the advice to start your IRA at 16 and kind of fill it, right, and you took that advice seriously, it makes a big difference, right? I see a lot of patients in their 60s and 70s that said, man, I really wish that somebody would have kind of looked through this when I was 30, because that 30 years of enhanced prevention makes a massive difference. So I would say if you're in that realm of between 30 and 45, and you're in this process where you've just been diagnosed, asking just to say, hey, can you draw some cardiovascular risk labs, right? One of the other things that we've done and spearheaded in this institution is use the imaging processes. So patients with cancer are going to get a lot of imaging, either through evaluations for metastasis and spread, or disease progression, or treatment success. That imaging comes with the primary goal of looking at tumor progression, regression, and cure, right? But the data is there to look at the cardiovascular system. So we showed in breast cancer patients that women with breast cancer were getting these PET and CT scans looking for spread, and a large majority of them had documentable cardiovascular disease on their CT scan they had no knowledge of. So it's another reasonable question to ask your providers. Hey, I just had a PET scan, or I just had a whole body CT looking for, my 3 or 5 year surveillance scan. Do you guys see any evidence of cardiovascular disease? Because it's there on a CT scan, you can see it. The vascular and atherosclerotic process can show up on CT scans, and it's something that's overlooked by radiologists. They've got one goal for that scan: look for cancer. So this is something that's overmissed.
I think what I would add to that in terms of the markers, in my realm, one of the best tests that we do is a test of your cardiorespiratory fitness, right? Or your overall cardiometabolic health. So that is the health of your heart, your lungs, your muscles, your blood vessels to move and use oxygen. And what we know is for about 13 different types of cancer, the fitter you are, the higher that VO2, the less likely the risk is that you'll develop that cancer. Colorectal cancer, esophageal cancer, stomach cancer. There's maybe some evidence now for lung cancer. Breast cancer is a big one. We also know that for every small improvement in your cardiorespiratory fitness, we decrease the risk of all-cause cardiovascular and cancer-related death by somewhere between 10 and 15%. So as Dr. Ray is saying, if we are aware of this marker, if we have tested this, then we've now got a benchmark by which to move you through. And then if you at some point do have that cancer diagnosis, we know that, again, for several different types of cancer, the more active you stay, the fitter you stay, you decrease your risk of recurrence and early death by up to 40%. Maybe less so in testicular cancer because the survival rate is relatively high compared to other types of cancer. But we know that this ability to take a marker of your cardiorespiratory fitness sets a really good benchmark for where you are, your likelihood of good progression, but also as a physiologist allows me to now enact change. I can look at your baseline data and say, right, this is what I need to do. I need to encourage you to do X training or Y training to get your body fitter and healthier, which will put you ultimately in a better place.
Yeah, we have a program here that we do that for specifically, right? You have a patient who's about to go through therapy. And one of the most impactful, important things is maintaining a fitness and functional capacity through therapy. It's much different during and after. I mean, a lot of men who've gone through this know this. And a lot of the questions that you got through Reddit and Facebook were addressing this concern. Hey, I feel different afterwards, right? And so the idea here is a pre-test where we measure some of these physiologic metrics can give us an insight into a patient before therapy and say, when you're in therapy, it's hard, but here are some exercises that are going to actually improve your pulmonary fitness during and afterwards. And the data is pretty clear, and not all cancers, mostly because they just haven't been studied well, that the more you do and the better you do it, the longer you'll live. And we've got data in all stages of cancer, metastatic cancers, you just do better. So that's a very reasonable and an important kind of facet in things. Exercise physiology and your cardiorespiratory fitness is probably one of the most powerful markers for mortality, just period. Everyone loves to talk about their cholesterol levels, and they love to talk about they get these ultrasounds of the heart that have this value called the ejection fraction, and people perseverate on these numbers. But really, we should be treating people, not numbers. And cardiorespiratory fitness really is the metric of the person, right? And so I agree. I think having some physiology beforehand, a series of traditional labs, identify the risk factors you're kind of more predisposed to, like diabetes, high blood pressure, high cholesterol, makes a big difference. This is an investment. So start early and put an effort into it, and over the long term.
So in regard to like the pre-treatment testing, obviously it sounds like at Mayo, you guys are kind of on the cutting edge of this, but somebody in Wyoming who's diagnosed with testicular cancer and they don't have like a center of excellence, is this something they can advocate for? Is this going to kind of go against the guidelines and maybe their insurance would deny it, or how does that look?
Yeah, I don't think it's these aren't an infrastructure can be unique, but these aren't tests that are specific or unique to an individual high impact center, right? So if you're diagnosed in a place where you feel like, well, yeah, I don't have access to one of those cares, advocating and saying, hey, do you know a good cardiologist or a pulmonary group that could do an exercise test to give me an idea of my oxygen consumption status? The term that's used colloquially is the VO2 test, right? That's a common test that's done in most infrastructures that do stress testing. So you can say, hey, I really want to know what my VO2 is, right? I really want to know what my heart rate response and recovery rates are to exercise. I really want to know what my cholesterol is, right? Those are labs and tests that are done almost ubiquitously across the country. And most big academic centers are willing to kind of go over that data too. So if you've got it done, you can certainly request, hey, can I get a referral to a doctor's that kind of knows and understands this infrastructure? Because of the globalization of medicine, the fact that we can have this Zoom meeting right now, right, speaks to the fact that, I spoke to 2 or 3 people from Ohio about this thing yesterday in clinic, right? So while it can be a little bit isolating when you feel like your medical community is small, there are avenues in which you can advocate and say, hey, I really want these lists of tests. And if you could place a referral for somebody in an academic center nearby just to go over them and talk about them, I think it's very reasonable, very, very achievable. And these tests Bryan can attest, these tests are not things that are overly expensive and rejected by insurance companies, mostly because the mortality data is very profound, right? Insurances want you to be healthy because it's cheaper for them. So if you can get this data, they're going to pay for it. So
I think that's actually the really key point there in terms of insurance providers covering it. These are relatively simple, relatively inexpensive tests, certainly compared to a lot of lab work and imaging, which can be very expensive and very complex. But in terms of the guidelines, which was the other part that you brought up, there's an entire movement now called exercise as medicine. And that's not just for cancer, that's for all sorts of other non-communicable diseases. But probably in the same time frame as the real development of the cardio-oncology world over the last 10 to 15 years or so, the evidence for exercise as a medicine, both pre, during, and post-cancer, has really grown. It's proliferated at an astonishing rate. And I think what that leads us to is the guidelines would now tell us that we want you to do these tests. We want you to get involved with an exercise program earlier, sooner, and safer. That's really what the baseline exercise test lets us do. It lets us ensure your safety. It lets us ensure that the plan we give you is individualized and therefore most effective. But back to the cardio-oncology realm of things, also lets us identify things that maybe we didn't know were there. That's the great thing about these cardiopulmonary exercise tests, this measure of VO2. They're actually meant to try and uncover abnormal physiology that we didn't know about, that we don't see at rest and we don't see under some normal blood work. So I think the evidence-based, the guidelines would tell us we should do this, but I think it comes with the benefit that it is also relatively cheap, and it potentially uncovers some other issues that we weren't aware of and can help with that primary and secondary prevention as well.
And just mentioning like, hey, I want an evaluation of my exercise performance, or, I feel a little bit more breathless when I exercise. Like I haven't gotten that level that I think I need to. Those are codes that are billable for these tests, right? So those are questions and inquiries that come with diagnoses codes that a provider can certainly place in there and say, hey, I want this patient evaluated because they don't feel themselves when they exercise, right?
Yeah.
That's an easy thing to get put in. And because it's so prevention heavy, it really financially is an impactful benefit for people who are looking to cover.
Yeah, I think to kind of put that in medical parlance, the term is new onset or worsening breathlessness.
Yeah.
As soon as you get that symptom, and that can be related to anything, then all of a sudden these exercise tests are effectively covered.
Interesting. Okay. I want to shift to kind of the delivery of the chemo and if that has any difference on outcomes. I know that it can be intravenous, which just directly into your hand or arm or whatever, like anything else, like you would do a blood draw, through a PICC line or through a Metaport, which is what I had. So does the Metaport, I guess, go directly into the heart, or are these going directly into arteries? Is there any kind of increased risk for cardiovascular disease when it's delivered straight to the?
That's a good question. So different chemos act a little bit differently. Some are a little bit more caustic and are administered in a concentration. So the blood likes to be 1% salt water. It's got a very particularity to it. And so that's what we call saline, is about 1% salt water. And so these drugs can come in concentrations that can either concentrate or dilute the blood, which makes the cell integrity more at risk. Cells can die if they're in exposures to changes in that concentration. If it becomes 3% like seawater is, cells die. If it becomes 0.5%, cells die. So the idea of administering it in an environment that's somewhat wide and open and can dilute out some of this effect is really important. So small veins tend to burn out because of this. They tend to become damaged because of this. So patients who have gone through this and they blew my vein, that concept of blow my vein predominantly comes from one of two mechanisms. One, they injured the vein when they stuck it with the needle, and that will shut the vein down and cause clotting and all this other stuff. And the other thing is this material, because its consistency is slightly different, and the material that's being delivered itself is in fact poisonous in some fashion. It's designed to kill cells, makes small enclosed environments like small veins much more predisposed to shutting down and having problems. So the predominant reason for using what we call central access is to allow for a wider space, more dilution of these chemicals to avoid some of those effects. Having something like a PICC or a port is important for patient experience as well, because you don't have to get stuck as much, right? You've got kind of an easy, somewhat convenient access. So a PICC and a port line, these are very long, hollow tubes that go from the access site, which is usually in the chest or upper arm, and that tube travels all the way back in the vein system to inside the first chamber of the heart, one of these chambers called the atrium. So those are designed to fit right in the middle, because now you have this big room that the tip of the catheter can kind of get in and dilute out, so to speak. We wouldn't put them in arteries. Yeah, there you go. There it is. Yeah. And so patients love having ports placed because blood draws, administration of medications, hydration, all this stuff can be done just through accessing a quick port. They don't have to be rotor-rooted and poked and prodded in their periphery and arms and legs looking for veins. It's a fairly accessible system, which is convenient for the whole system, really. It's a surgical procedure, a minor one, but it's still a surgical procedure to have one placed. But there is a litany of conveniences from that standpoint. We don't do anything in the arteries. And the reason for that is the arteries are a little bit more predisposed to forming blood clots. It's a higher pressure system. So the blood pressure your blood pressure in your arm, like the artery system, is like 120. That's the ideal blood pressure. In the veins, it's like 10. So there's magnitudes higher of pressure in the artery system than in the veins, which creates a very difficult concept and physiology to be able to administer medicines. So nothing would get administered in an artery. It would all be through some vein system. The most convenient source would be through what we call a central vein, meaning one of the big veins in the chest or ending right in the first chamber of the heart. And the concept there is ease of access for the patients and the nurses, and to really kind of dilute out the chemical that's in there to make sure that that doesn't change some of the consistency of the blood and doesn't irritate the lining of the vessel, because the stuff that's being administered is caustic to some extent. So
interesting. Okay. Yeah, I was showing you my port here I have hanging, which I probably am not supposed to have. I was using it as a bookmark for a while, but I think it's probably still got some chemo residue in it, and I don't know, probably not great.
Yeah. I didn't see anything, so
Yeah.
I don't know.
Yeah, just it's a keychain from here. You're fine.
Let's talk about the specific chemos for testicular cancer. It's typically bleomycin, etoposide, cisplatin that are used, sometimes carboplatin, ifosfamide, and vinblastine. But let's just, focus on BEP. Now, are those at any increased risk compared to, chemos you would see used in breast cancer or colon cancer or anything else?
Yeah, they are a little bit lower in risk from a cardiovascular standpoint. These are what we would classify as systemic chemotherapies. And so chemo, for the most part, is a broad term that we would use. In medicine, we would consider a chemotherapy an agent that we're giving, that the design of that drug is to enact cell death through some mechanism by disrupting either the replication of the cell or the metabolism of the cell. But it's not specific or targeted to the cancer cell itself, meaning that system of killing a cell through not allowing it to replicate is indiscriminate. It's going to go to any cell that it gets administered to and enact the same impact. And that's why the side effects from a lot of chemos are similar. Because they're actually impacting the cells that typically replicate more. The lining of your GI tract, your hair, your skin, your fingernails. These are systems that tend to cause a lot of cell turnover. And these are drugs that tend to affect cell turnover mechanisms, replication mechanisms. And that's where you're seeing the big impact from that. So that's the list or silo of chemo. There's a whole litany of or big world of other therapies that are very targeted and specific, but the chemo is non-specific. Those drugs that you listed have some cardiovascular impact, but not nearly as impactful and as risky as the ones that we would see maybe in lymphoma or sarcoma, or certainly some in the breast cancer world, where the risk is going to be much higher. That's a mechanistic issue. The mechanism predominantly affecting some of the architecture of musculature, as well as the infrastructure of consuming oxygen. The powerhouse of the cell from high school biology, which is the mitochondria, is impacted by other chemos a little bit more heavily than the ones we use in testicular cancer. Etoposide, which is a pretty mainstay. We do flip around with cisplatin and carboplatin and some of what they call the platinum-based therapies. The etoposide would be probably the most cardiac toxic in that list. It's got the most vascular risk to it. It tends to cause the most irritability to blood vessels, where vessels can spasm or tighten down. They can become injured and more predisposed to heart attacks or tears. These are pretty rare events, though. So we're not talking like where we would see a 5 to 15% risk and maybe in a breast cancer therapy. We're talking less than 1% risks during therapy in these testicular cancer therapies. So for the most part, they're not overly egregious or dangerous from a cardiovascular system. With that said, if you're going into therapy with already predisposed cardiovascular risks, especially with etoposide, like you've had a prior heart attack or you have a strong family history where every male in your family has had a problem, then it does become important to make sure that we've established that those risk factors are mitigated, reduced, those kinds of things. Wouldn't be a situation where we'd say, well, just scrap the etoposide. That's not appropriate because it is an important and impactful therapy for this. But it's something to be aware of. It's reasonable to kind of avoid the insult to injury effect, right? But to traditionally not as dangerous as some of the chemotherapies we would use in other lines or cancers.
In the first part of that answer, I was feeling good, and then you said the family history, and then I was like, oh no. Yeah, I have never eaten the best. I never was great at exercise, and I have my cardio labs here, but we don't have to get into that. But yeah, not looking good for me, but I guess I need to exercise more.
So, I mean, it really does matter. I mean, who you are matters a lot, right? And if we were to think about like long-term impacts, right? The long-term impact is blood vessel health is going to be slightly worsened by almost any systemic chemotherapy. It really does impact the blood vessels. When I have my colleagues put in stents and things in patients who have had recent chemotherapy, they can feel and tell that the vessel architecture is slightly different. It's a little more prone to tearing. It's a little bit more weakened. And these are therapies, lines of therapies that we wouldn't have traditionally called cardiac toxic, but we see, and my colleagues have been very upfront when I send them patients going, ooh, man, that blood vessel was not as strong as I would have expected it to be. So we know there's an impact from the blood vessel standpoint. I also think it's important to understand the physiology of what we're thinking of. When we think about the term atherosclerosis, which is cholesterol hardening of our arteries, right? That's the condition that leads to heart attacks and a large proportion of strokes. I think the consensus amongst a lot of lay people, even primary care doctors and some, would be that you've got this drain pipe, right? And it's just like slowly filling with like fat goo on the side. And that's what this kind of heart disease is. And that's not really what this is. It's a slow buildup over time of cholesterol particles that are not supposed to be trapped in the blood vessel environment, but they get there. And then the immune system is recruited to try to get those out. Like, we don't want this cholesterol here. It's being built up. It's causing architecture and infrastructure issues. But the immune system doesn't have any mechanism for that. It's not designed to fight cholesterol, right? It fights bacteria, viruses, cancer, these kinds of things. And so it revs up. It kills all of the good cells around the cholesterol. It creates this collateral damage that leads to the blood vessel being weakened further. And so if you've gotten chemotherapy where we see some of this architectural change, this vascular area where it's slightly less, slightly more weak, slightly less effective in containment, then you're more at risk. A heart attack happens not when this vessel goes from 0% blocked to 100% blocked. It happens when the vessel is trying to contain this inflammatory goo and it ruptures, it tears. It can't hold this thing on. We referenced earlier about you'll look at your CT scans and get a picture of vascular phenomena. And that's predominantly through the calcification effect. So the body tries to restore integrity to your blood vessels. It's trying to strengthen those blood vessels that have been damaged because of this inflammatory issue attacking that cholesterol. And the mechanism it does it with is the use of calcium. It tries to harden and strengthen and kind of cement the layers of the vessel back together to keep them from tearing. So when we see calcification in a blood vessel on CT, then we're seeing the manifestation of this damage to a blood vessel where those are areas that were more predisposed to being torn and ruptured that the body is figuring out, right? And that's mechanistically also associated with the aging process. So we can correlate that with age, right? If you're a 40-year-old male and you get a scan for like surveillance and you got calcification in your heart, that's 20 years early, right? That's not supposed to be there. And so that's impactful because we can say we have evidence now that this is happening and progressing faster than we're supposed to be, right? You're 20 years older on the inside, quote unquote. And so that's an important facet because I think people just think, oh, I eat a steak and this thing just kind of builds up and it's just like a slow pipe thing that's kind of narrowing. No, that's not really what it is. It's the body's response to what you put in your mouth. It's the body's response to how you exercise that matters most. And you can't do one for the other, right? If you have an approach for cardiovascular disease, it's like making a bar stool. It needs at least 3 legs. If you try, and they all need to be the same length too, right? You can't say, I'm just going to eat right and I'm going to be fine. It doesn't work that way, because eating right attacks this process slightly different than exercise attacks this process, right? They're not the same thing, and you can't substitute one for the other.
Yeah, I think that's absolutely right. And, you said about doing more exercise. I think there's a few good things that we can focus on in terms of how you start that process. One is what it will do for you. I mentioned the term exercise as medicine earlier, and I think that term really makes sense. I'm a little biased as an exercise physiologist, but I don't know many traditional medicines that improve the function of multiple organ systems. What I mean by that is there's not necessarily many medicines that will improve heart function, lung function, muscle function, brain function all at the same time. Exercise will do that. Exercise is proven to do that. Hence the term exercise as medicine. And when we think about all of the bad things that Dr. Ray's just gone through, fixate on the vascular health issue. From an exercise standpoint, even small amounts of exercise will improve not only the number of blood vessels you have, it will improve the integrity and the strength of those blood vessels, and it will help prevent the buildup of that cholesterol that then becomes calcified and then becomes the problem. So again, exercise isn't just about the direct relation to cancer per se, but it can actually combat many of the deleterious changes of the cancer process, including the medical therapies that we get. So from a physiologic standpoint, it's good at preventing and reversing the adverse effects that we would see. But the really good news is, as well, you will hear things like, more is better. And I think that's kind of true for exercise. The more you do, the higher the intensity, the more the volume, the better you're going to get, the better benefit you're going to get. But what we're now understanding is that even small amounts of exercise, even just standing up and moving a little bit more, can be associated with really big improvements in things like blood pressure, lipid control, cholesterol control, blood vessel function, cardiac function. There was a really great study done out of Canada a year or two ago now, and they took otherwise sedentary individuals who worked in an office job, so spent most of their day sitting, didn't really get up, didn't move, and they had them walk a flight of stairs 3 times a day, 4 times a week. And over the course of 6 weeks, every single cardiovascular risk factor they measured got better, just by doing that small amount of exercise. So this idea of exercise snacking. So even if you're intimidated by it, you see the big billboards that you must wear the Lycra pants and you must be on TikTok and you must do all of this. That's not necessarily true. Even small amounts of exercise will help mitigate all of the things that, was just been discussed there in terms of the adverse effects of the cancer therapies.
Yeah, that's one of the things I stress with patients is you don't have to join a gym and flip tractor tires and hit stuff with sledgehammers, right? I mean, that doesn't have to be the case from a cardiovascular standpoint. The body is designed to be adaptive, right? What you're doing is you're providing feedback to a system. You're providing feedback to an infrastructure, right? If you want to add lanes to a highway system, you can't do that without justifying a traffic problem, right? No one's going to pay for that infrastructure. No one's going to put that mechanism in place. And so that's what exercise is designed to do, is it's designed to create an environment to show an inefficiency and teach the body how to improve itself through that. And that's at any level, right? If you have a 1 stoplight town that needs to add an extra lane, or you need a 10th lane in Los Angeles, right? Either way, while the infrastructure and exercise are 2 different things, the feedback system is the same. Yep. One of the questions that you had kind of sent that you'd gotten through the Reddit was like the standing desk thing. That's been a phenomenon, right? There's a lot of debate about the standing desk thing. There's probably some value there, better than sitting, but reality, exercise requires movement. Movement. So a desk that's got a treadmill to it, like one of the treadmill desks, is much, much, much more effective. Magnitudes more effective in terms of improving your longevity and fitness than just standing. And so that's an important metric and thing to think about. Standing's better than sitting, but you're talking many magnitudes better by actually physically moving. So a walking desk is probably a much more superior strategy for somebody who's got a desk job that wants to become more physically active.
Yeah, interesting. I want to get to some of these Reddit questions before we run out of time, and I do have a couple more of my own. But to add to that, I did buy myself a walking pad after I got these cholesterol labs came through on my chart at like 4 a.m. I bought a treadmill at 5 a.m. But let's get to some of these anecdotal questions. The first one is, underwent 3 cycles of BEP chemo, noticed the second week after the week of etoposide and cisplatin that my resting heart rate was higher than normal. Not sure if it was the chemo or the steroids. What could be causing a higher than normal heart rate 14 months on, and my resting heart rate is now 60 beats per minute?
Yeah, that's a great question, right? So when it comes to heart rate, there are a couple of things I try to stress. One is knowing the difference between a physiologic heart rate and a non-physiologic heart rate. So the misconception here is that the heart decides its rate, and that's not true. If the heart is deciding the rate, it's an arrhythmia, it's an abnormal rhythm. You flipped into something pathologic. The body is the thing that is telling the heart the rate, and it's doing that through a series of feedbacks and cycles. The amount of oxygen that's in the system, the amount of hemoglobin that's in the system, the pressure in the system, are all feedbacks. If you see a bear with your eyes, you will get a feedback that will create adrenaline, and that adrenaline will then stimulate the heart and raise the heart rate. So the heart doesn't decide the beat. This body is deciding the beat. And so there are physiologic metrics that Bryan is much smarter in explaining in this fashion that are likely to lead. So when you see a change in heart rate, the first question is this a response? Is the body reacting to it appropriately? Is there a physiology that makes sense? And Bryan can help with some of that. And so we don't want to treat that, right? We're not smarter than the body. So a lot of people have this itch, like my heart rate's 110. I don't like that. I don't want it to be 110. I was used to 60, right? And so you want to put yourself on these drugs to lower the heart rate. Well, all you're doing is taking something where the system's at play, right? If you were being chased by a bear and I gave you a drug that made you slower, you'd be mad at me, right? And so you don't want that. But Bryan, kind of give some insight. What do you think would be a cause for high heart rates in patients who are getting through some of these systemic therapies?
Yeah, it's a common question we get, not just in our cancer survivors, but you said at the top of the podcast, my role in sports cardiology. It's a very common question. Why is my resting heart rate doing this? And we have the exact same conversation that Dr. Gray just highlighted. I think where I would start in terms of the person who asked the question, the fact their resting heart rate is now back down in the 60s, that's a good thing. That's completely normal heart rate. They have recovered. That sounds fantastic. Without seeing a rhythm strip and not knowing what's going on, the heart rate itself sounds fantastic. In terms of what might cause an elevated resting heart rate in some of your listeners, there's probably 2 or 3 different factors. One is purely the process itself. Dr. Ray said about if you see a bear, your heart rate is going to go up. Well, many of your listeners will go through periods of stress, depression, anxiety, sleepless nights. All of these things will cause an elevation in resting heart rate, right? Just the psychological component of what is going on will cause a resting heart rate. Some of the cancer medications can cause electrolyte imbalances. So down at the physiological level, the electrolytes that are used to control our heart rate, control our body, are imbalanced enough that you will see a spike and increase in your resting heart rate. And then there's the deconditioning part, which is something Dr. Ray and I talk about all the time, right? What does that actually mean? So some of the steroid treatments that your listeners will get will cause things like muscle wasting, decrease in muscle strength, and all of that will create a feedback system to increase heart rate, to deliver. Dr. Ray described the heart as like a pump system. Well, if there's a signal coming from the periphery saying we need more information, well, one way of doing that is speeding up the heart rate. So again, it comes back to the idea of it's not the heart that's in control per se, it's the information coming back to it from the body. So if you have this kind of muscle deconditioning, muscle wasting strategy going on, or effect going on, then it likely sends a signal to the brain, which sends a signal to the heart that says we just need more delivery of goods. And one of the ways of doing that is increasing your heart rate. It can also directly impact that deconditioning component, can directly impact the nerve that controls your heart rate too. So we see in athletes, that nerve is under what we call more kind of the brake or the parasympathetic, right? And you'll see a lower heart rate. Those who are less trained, it will go the opposite way and the heart rate will elevate. So it's likely a mix of the kind of the situation the patients find themselves in. sleepless nights, stress, anxiety will all cause an increase in the heart rate. We likely have things going on at the muscle level, the molecular level. Dr. Ray mentioned the mitochondria. The muscles are less able to use oxygen. If they're less able to use oxygen, then they need a bigger delivery, right? We just need to give it more. And so heart rate increasing can be one of those things. And then just how the heart rate is neurally controlled through just a process of being less active can impact heart rate to cause it to raise as well. But again, I think it should be considered somewhat normal to see that heart rate go up. The time it takes to recover is incredibly individual. Probably depends on the course of your treatment, how severe the side effects were, how quickly you can get back into some type of fitness regimen, especially if you were fit beforehand. But again, from the person who asked the question, the fact that I think you said 14 months on, their heart rate's now back in the 60s, that wouldn't cause any alarm, right? That sounds fantastic right now and sounds like a natural process.
Yeah, that's the recovery rate we see for, I mean, this is always a question from people who were physically fit before, and now they know the difference, right? Our couch potatoes don't tend to have this concern because they don't know the difference, because chemo is a deconditioning state. You went from, even if you were physically fit, chemo will invariably create a deconditioned state through the mechanisms and the physiology that happen. So that the people who are most noticed of this are the ones who were really fit before and are like, whoa, this is not me. And that's true. It's not what you used to be. And that's a physiologic change that can recover. The average kind of recovery time and rate we see in our clinic is around between 6 and 18 months. Yeah. This kind of 1 year of being patient, being diligent, being purposeful, rebuilding the infrastructure, right? You got to create that feedback to learn, add those lanes to the highway. That has to be taught. It can take as much as a year.
Very interesting. And speaking of responses, talking about this like almost gives me a vasovagal response. Like I'm almost about to pass out over here. The next question is a more simple one. If we had chemo, should we be consulting with a cardiologist on a regular basis?
About regular, but I think, again, this idea of number one killer in the United States, number one killer in survivors of most malignancies is going to be cardiovascular disease in a lot of states. So having that assessment of, am I at risk? Did I come to my cancer therapy with risks that I need to change? And do I need to continue to change long term? One of the things that we've harped with patients in the survivor setting is to have somebody formally assess your physical fitness every probably 5 years is a reasonable kind of thought, right? So even if you don't carry traditional risk factors like high cholesterol, diabetes, having somebody double check and make sure that you're out exercising your peer group every 5 years is good, because if you are outside exercising your peer groups, you're going to outlive your peer groups. And if you're not, having somebody that kind of say, hey, when you got on that treadmill, you operated about 60% of what we predicted. We got to work. We got to work on that, right? And that's that kind of double check. A lot of things kind of become changed and complacent, especially after cancer therapy. It's like this mountain you've climbed. And it's like, okay, now it's time to break. And that's natural. That's normal. But it's a longitudinal process. So not necessarily regular, but knowing your physical fitness is staying the way it is longitudinally is good. And if you've got risk factors or family history, then it's probably reasonable to see somebody pretty periodically.
All right. So I need to meet somebody. So this one's probably for Dr. Taylor. It says, did BEP 4 cycles 2012. Why, in my opinion, does it feel like I've lost my second gear to turn it up a notch when running? It seems like my second wind is gone, harder to sprint. Now, this person is obviously 13 years older, but is there a chance it's related to their chemo?
Yeah, that's a really good question, and I actually think it follows on from the kind of the heart rate conversation, because I think many of the mechanisms that are causing the elevated heart rate are likely causing the symptoms that your listeners asking. Is it related to an increase in 13 years of age? Yeah, possibly, probably. There's definitely an element in there, right? We all wish we were 21 again. We always remember our halcyon days, whatever we thought we were really good at. So that's definitely part of it. But again, when you think about the process of cancer, a cancer diagnosis, and the cancer treatment, it can have quite a profound effect, does have quite a profound effect on our physiology and the physiology that's meant to make us exercise, right? The biggest thing that we're kind of looking at here at Mayo, and the biggest thing that we're targeting again, is that muscle architecture. So if you think about how we exercise, there's two key components to predicting or measuring how well someone can exercise. It's how well we take the oxygen from the air and flow it to our muscles, right? That's kind of the convective responses. The heart is clearly a central component in that. That's one of the pump systems. The second big part is how our muscles then use that oxygen, right? That's the diffusion of the oxygen into the muscle cells and then its use to generate energy, to generate our ATP, or adenosine triphosphate, which is the energy molecule we use to power ourselves. And that's where we think a big part of the issue might be, whether it is through the cancer itself, whether it is through the treatment, whether it be the chemo or the steroid effect, or whether it be through some form of deconditioning, the ability of the muscle, and in particular those mitochondria, those small organelles that allow you to use oxygen and generate energy, are likely not functioning anywhere near at the level we would hope them to do. Whether that's because there's less of them, less of those mitochondria, whether it's because the small blood vessels that surround the muscle cells aren't as many and we can't get as much oxygen to them, or whether it's because within inside the mitochondria themselves, the little enzymes that allow us to move and use oxygen aren't as plentiful, probably a little bit of everything. But the cascade effect of that is, again, if the muscles can't use as much oxygen, then what we do is we trip from the ability to use oxygen, exercise feels easy, into a state where we're exercising not in a complete absence of oxygen, that's a misnomer, but we're relying on less oxygen-dependent pathways. By definition, that exercise comes at a cost. We generate more carbon dioxide. We generate more lactic acid. It just feels harder. It creates signals that go back to the brain that cause the body to drive a little bit harder for a given level of exercise. So previously, a jog at 6 miles an hour might have been a zone 2 for this person, but now, because of that muscular issue, it's actually a zone 3 or a zone 4. And by definition, that's just going to feel harder. The good news is again, along with the time frame we're talking about, you will begin to see improvements over time. This question is caveated by the age change, of course, but I suspect that might be part of what's going on. The ship hasn't quite righted back to the cancer diagnosis or pre-cancer diagnosis level, and it's likely causing a cascade of symptoms that just make the exercise feel harder.
It's also important to make sure that you don't have a supply-demand problem other places, right? As you age 14 more years, the infrastructure and vascular change, like how do we know you don't have a blockage that's just strangling the environment, right? So it would be very reasonable. I advocate any patient who's used to kind of knowing how they exercise and then now feeling like that's not the same and they've been fairly consistent, that's always a sign that there's a supply demand problem. And cardiologist is a great and strategy to kind of go through that supply demand question.
And that kind of goes in full cycle back to the should they see a cardiologist, what types of testing should they do? It's almost back to one of our first answers. Yeah. That getting this baseline testing, having that routine follow-up every 3 or 5 years, especially if you're seeing a deleterious change, things were at this level and they've dropped, or you just can't get back up to the level you anticipate you should be. This type of individual you're talking about, I assume, is quite in tune with their body. They kind of know what's going on, and that will be the time to go get it checked. And Dr. Ray just said, just make sure there is nothing else that we're missing that's causing this effect too.
So this next one kind of goes along with timeline. I'm going to kind of reframe their question to fit what we've been talking about, but how long after chemo should somebody expect to kind of not be their full self? And then when does it become like, okay, now something I know is wrong?
Yeah, I think within 1 to 2 cycles, most patients are going to know this is new, this is different. That effect, it's a little bit accumulative. There's an added or stacked effect. So with each subsequent cycle, it's going to be slightly more noticeable. And so I think creating an idea that there are normals to the feelings in chemo that are important. You will feel slightly more deconditioned. Your heart rate will likely slightly climb, maybe 10 to 30 points higher than what it was before. tasks that were commonplace to you may now feel more taxing, right? I used to run 5 miles a day. Now it's hard for me to run 1 mile a day. In chemotherapy and during, that's a commonplace. Following the recovery process is variable for the patient. There's a genetic component. People are built genetically to be just more physically fit, and they just kind of breeze through these things and don't have a long, prolonged recovery phase. That's a genetic predisposition. There's nothing you can exercise better to achieve that. Like, that's just somebody who is literally better. But if you are not putting effort into your recovery, it will by definition be more prolonged. And so you will notice that sloggy feeling and effect will be a lot longer. And that's why when we talk to patients about the recovery expectations, we give a pretty big variability, 6 months to 18 months, because that's varying based on who you are genetically, as well as what effort and infrastructure did you put into place afterwards to actively put that infrastructure in, right? It would be like somebody coming in and bombing a city, and then people of the city go, well, how long is it going to take to rebuild? And the question is, well, you guys are the ones rebuilding it. So how long are you going to put effort into rebuilding this thing, right? It's not like surgery where somebody can cut your gallbladder out. You can sit on the couch and you will heal from that surgery, right? This isn't the same thing. This is an active rebuilding state. And so, in that kind of time frames, 6 to 18 months, most patients feel a little bit like themselves. There's a lot of patients that feel slightly less. One of the thoughts we've had is, did they just get a little older on the inside from this chemo effect, right? So now you're used to exercising here, and now it's slightly here. Well, this is the exercise performance of somebody maybe 10 years older than you. And that's maybe why you've got some of that ceiling effect too.
Yeah, I think when I describe this process to patients, it's one of the harder things to do, right? Because everyone wants a definitive answer. And this is one of those questions in cancer in general. Cancer recovery is one of those things that definitive answers are kind of hard to come by. But I try and describe it to them in 4 phases. And those 4 phases can take anywhere from that kind of 6 to 12 month range, right? So phase 1 would be in the treatment process themselves, where you're going to get more fatigue, you're going to get more anxiety, you're going to get more malaise. What we're trying to do there from an exercise standpoint, the worst thing that you can do, if you can at all help it, is be sedentary, right? You've got to try and keep exercising through that treatment, but at a very light level, right? So very light, very easy, moderate walking, easy cycling, things like that. So that's going to be phase 1, and that's going to take, 6 to 12 weeks, depending on who you are. Phase 2 is once you've cleared that treatment, and now you're basically trying to just rebuild the detrimental effects that we've talked about of the treatment, right? You're just trying to get your baseline back. So now we're pushing into that more moderate, a tiny little bit more breathless. Again, that's now going to be the 12 weeks to kind of 6 month period. And then after that, we're beginning to build back fitness in phase 3 with the idea of phase 4. By about 12 months, you're effectively back to normal. But this is not linear. It's not linear within the same person, let alone between people. Some people might have a really long drawn out phase 1, and then something happens and their phase 2 accelerates and is very quickly. Or they might recover super quickly through phase 1 and phase 2, but phase 3 is harder to attain. That's likely genetics, that's likely age, it's likely the course of the cancer. But I think that kind of 12 month is a good marker for everyone, knowing that you might be a little shorter or a little longer. And really key, it's not like everyone is on the same trajectory. And not only that, you don't follow the same trajectory the whole way through your individualized process. There are ups and downs.
We're kind of coming down the home stretch here, and I know, Dr. Taylor, you've got a patient to see. Scanning the list of questions from Reddit and Facebook, it seems like we've kind of answered all of them in one way or another. But the last one that remains is if you, I guess, have low testosterone from your testicular cancer treatment, is there any negative cardio effect of maybe the low testosterone or the treatment?
Yeah, that's a tough question to answer. That is a $1 million question that's been debated over and over and over again in a lot of cancer facets, right? We see the opposite in men with prostate cancer, where we're trying to purposely take their testosterone away, right? I think the important thing to kind of focus on is trying to achieve physiology is pretty safe usually, right? So you no longer make testosterone, you are genetically male. There's a lot of infrastructure that needs to be already in that place and you're trying to restore that previous physiology, to that extent, probably not going to dramatically increase your cardiovascular risks. And the reason for that is we do see that men with prostate cancer, where we strip them of their testosterone, right, they actually have slightly higher cardiovascular risks and events. So it's not as binary as saying testosterone is a bad hormone and estrogen is a protective hormone. And the reason for that is testosterone, estrogen, and progesterone are hormones that bind to things like receptors, these other like lock and keys that then create a cascade of events. And those three hormones have more receptors and impact DNA expression, the making of new proteins, the creating of a new infrastructure, more than any other signaling process in the body. And so when we try to trivialize, like, well, I'm going to start testosterone or stop testosterone, and you pinpoint, we're talking about hundreds of thousands of cascading events that a supercomputer might at some point be able to figure out, but probably at this point can't. So it's really difficult for me to provide straightforward advice for patients. I think getting back to physiology, very reasonable. I think very appropriate. We want you exercising. If you don't have testosterone and you have no motivation to exercise, that's a deleterious and detrimental impact for you, right? At the same extent, if you are overusing your testosterone in an event and effort to kind of supra-normal yourself, you will injure and create an environment of negative impact. No question. That's well established, right? But trying to achieve physiology, we believe, is fairly safe and very appropriate and likely leads to much higher motivation for activity and exercise for patients. So I wouldn't trivialize this as testosterone is always bad, estrogen is protective. Doesn't work that way. It is way more complex than we really truly understand. The goal here is we want you feeling better, we want you exercising, but we don't want you going overboard.
Gotcha. Yeah, just to put a bow on it, I was going into this feeling like I was going to die by 50. Maybe I still am based on my family history, but I'm feeling a little bit better about it. It feels like there's things that I can do to reverse things. I just need to have the motivation. Dr. Ray and Dr. Taylor, thank you so much for being on It Takes Balls.
Oh, we appreciate it. This is a fantastic forum.
That was fun. That was great.
Well,
appreciate it.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org.